going on. Let's move on to the contracts report, if that's okay with you, Commissioner Chung.
Yes, please.
Okay.
Good afternoon, Commissioner. This month's Health Commission report contains 6 items. However, we will be pulling the final item from the report for health advocates and bringing this back next month to the meeting of November 7th. Health advocates was approved at last month's Health Commission meeting, and it is also being presented at the Board of Supervisors for approval. This month's revisiting of the health advocates item was to update the total contract amount with contingency to align with the evolving amount to be approved by the Board of Supervisors. The information for the health advocates at this point needs to be pulled, updated, and will be presented next month.
Okay.
Thank you. The first item we have is for a contract with Hatchell, Tabernick and Associates, also known as HTA. The requested action is the approval of a contract amendment with HTA to increase the total contract amount with contingency to reflect an amount of $3,927,282. The contract term of July 1, 2020 through June 30th of 2025 remains the same. The contract was previously approved by the Health Commission on August 1st, 2017. HTA will continue to support and coordinate DPH data collection activities and program planning, and to provide technical assistance with various special projects. The proposed amendment was authorized under RFQ 36-2017. The department is requesting the approval of a total contract amount of $3,927,282, which is an increase in the proposed annual amount of $1,094,630 due to additional funding for fiscal years 23-24 and 24-25. I believe we have Jessica Brown, Director of the Office of Justice, Equity, Diversity, and Inclusion, as well as the Mental Health Services Act Systems of Care, who is attending and can answer any programmatic questions you may have.
Yeah, thank you. So just for clarity, so the contract term has not changed. It's just the funding amount has changed, and that's why it's brought back to us.
Correct.
Okay.
The additional amount of $1,094,000.
Okay.
It's okay to move forward, Commissioner?
Yeah.
Okay. The second item is a contract amendment with McKesson Corporation to provide pharmacy distribution services of a broad range of pharmaceuticals to be used by the department in the provision of its services. This contract was last approved by the Health Commission at the May 7th, 2019 meeting. The increase in funding represents the extension of the contract of 4 additional years, as well as the following factors: an increase to the annual pharmaceutical inflation factor applied in the contract budget to 15% each year from the prior inflation factor of 11%. The inflation factor is applied to each year of the contract extension and also applied to the built-in holdover. The holdover year is based on the last 12 months of the contract and is included in the requested spending authority in order to ensure that the department is not without access to spending authority for pharmaceuticals if there are unanticipated delays at the time when we begin to plan for the next renewal cycle. And also the inclusion of vaccines to treat and prevent diseases such as COVID, HIV, and RSV under pharmaceutical innovation initiatives. Pharmaceutical innovation initiatives is a section included in the contract to allow the department to set aside contract spending authority to be able to quickly procure and secure access to new treatments that may come online during the term of the contract. I wanted to note that we have 2 McKesson contracts. I'm going to introduce the second one, and then we have the second item, which follows the monthly report. And then we have David E. Smith, who's the Chief Pharmacy Officer with DPH, who has a short PowerPoint of a few slides that he wanted to provide a little bit more context due to the large dollar amount of these 2 items. And then afterwards, we'll take questions on both, but the slides are for both contracts.
Okay.
Does that work?
Sounds good.
Okay. Contract number 3 is with McKesson Plasma and Biologics, LLC. This is a contract amendment with McKesson Plasma and Biologics to provide pharmacy distribution services for specialty drugs and gene therapies to be used by the department in the provision of its services. This contract was also last approved by the Health Commission at the May 7th, 2019 meeting. The increase in funding represents the extension of the contract for another 4 years, as the other was, as well as the following factor. Also, again, increasing the annual pharmaceutical inflation factor applied in the contract budget to 44% each year, an increase from the prior inflation factor of 40%. These are higher because they're plasma and biologics. The inflation factors applied to each year of the contract extension and also applied to the built-in holdover. Again, the holdover is based on the last 12 months of the contract and it's included in the requested spending authority in order to ensure that the department is not without access to biologics and plasma treatments if there are any unanticipated delays at the time we begin to plan for the next renewal cycle. McKesson Plasma and Biologics LLC focuses on plasma and recombinant products such as IVIG, SCIG, coagulation factors, and albumin that focus on oncology, rheumatology, neurology, immunology, infectious disease and rare disease, gene therapy, and surgical biologics. The pharmaceuticals used in the specialty care environment tend to be significantly more expensive and subject to higher costs because of the specialty nature and their ability to be given outside of the hospital setting, thereby shifting cost of care to the outpatient setting. Although expensive, pharmaceuticals in this area can be reimbursed and can typically prevent significant hospitalization or can cure ailments, thereby resulting in lower long-term treatment costs for patients and better outcomes. We have David E. Smith, Chief Pharmacy Officer with DPH, who has presented some slides that Mark will pull up and share on the screen that he'll present to you. Then we're happy to answer any questions you may have.
Okay. So why don't we go through the slides first? I do have questions, but it's more about the fiscal part. Like
Okay, would you rather ask them now or after he goes through the
after the presentation?
Okay.
Yeah.
Great.
Great. Commissioner Chung, can you hear me okay?
Yes.
Wonderful. So thank you. My name is David Smith. I'm the Chief Pharmacy Officer for DPH. And as Dean just alluded, we have the two contracts that we're asking for increased budget authority. Those contracts have been in place and approved by the Health Commission in 2019 and the board in 2020. In addition to increased budget authority to procure the medications, there are some updated terms that actually allow greater savings for DPH during this extended period. Overall, the goal of this contract is really to make sure we have the meds we need and we can get them in a nimble and cost-effective way. Next slide. I don't know
Sorry,
if I
give me a
can
second.
change the slide.
Oh, sorry. I apologize.
That's okay. That happens to me frequently.
Okay, there we go.
Sometimes drug procurement can be confusing for me. I imagine it is for other people. So a quick overview of kind of what McKesson does in the overall marketplace. First and foremost, McKesson doesn't actually determine or negotiate drug prices for DPH. Their role is really as a distributor. So they purchase drugs from manufacturers in bulk. And then McKesson dispenses the drugs to DPH pharmacies and sites per our request, only those that we order, and then we pay McKesson. So they don't determine how much we pay. And right now they distribute 90% of the medications or biologics to our pharmacies using our two current contracts. McKesson as a whole is one of the largest distributors of medications in the U.S. They cover over 5,000 hospitals. They are huge in the market in the field. And why overall do we need a distributor? It really it streamlines our process to allow for a single place where we can order reliably obtain medications. Otherwise, we would have to maintain about 575 contracts, and I think we all know contracting the city is challenging even for a single contract. So trying to manage 575 would be overwhelming for everyone involved. Next slide, please. And I fully acknowledge, as you noted, I think the thing that sticks out is just the cost associated with this budget authority. And so I think it was helpful to kind of address that elephant in the room. One thing is how we try and minimize how much we pay for drugs. So McKesson has different accounts of ours that we utilize, and they load into their system. Those accounts can be the more expensive, which is called wholesale acquisition. We get discounted drugs through our group purchasing organization, which we utilize Vizient. And we also participate in the 340B federal drug discount program. And all of those really allows us to pick whatever account we need to get the cheapest price for this drug. And then in addition, McKesson, because they can buy in bulk, they can add additional savings on top of those, which has been great. And then on the flip side, even though these drugs are getting significantly more expensive, we also get reimbursed. So for any patients that have insurance, we get reimbursed. So overall, we actually get savings on these drugs. And while not everyone in our system has insurance, we're able to recoup enough savings from our reimbursement compared to our spend that we can use that money to actually help support those uninsured patients in our network so that they can have the medication access that we're committed to as a city in an equitable way to those that may have Medicaid. Next slide. And also because of the large amount, we take performance monitoring of the vendor very seriously. So we meet quarterly and annually. We do compliance meetings to make sure that they are giving us the discounts on these accounts that we are owed and that they're meeting the additional discounts per the contract. The pharmacy departments at each site also do monthly audits, and we're able to do on-demand reporting using the web interface. So if we ever need to dive into specifics around how much we paid versus how much we expected to pay, we can do that. In addition, the pharmacy department, each location, all pricing and information around use of any drug is heavily scrutinized before it's ever brought into McKesson and onboarded. And so that's part of ongoing evaluations for how much, are we using this in the intended way that we thought when drugs were brought into the system? And so we have a very, very tight control on that. And then finally, if there are any customer complaints, or client complaints or patient complaints about McKesson, those are also addressed at these meetings. And then the last part in terms of why McKesson, we've worked with McKesson for quite a while. They've been a very strong partner. Two examples I think stand out for our department recently were that there were several national drug shortages causing significant change in care, especially for critical care patients. They were wonderful at making sure that we got the drugs we needed so our patients were actually not affected, which wasn't the case with a lot of other programs. And then also that it helps us participate and get other savings. So one is Governor Newsom had a state pharmaceutical purchasing program where they actually negotiated directly with pharmaceuticals and utilized the state purchasing power, and we're utilizing that in our jail health systems, and that wouldn't have been possible without McKesson. So with that, I'm happy to take any more additional questions and request your approval.
Okay, so let's try with some simpler question. So my understanding is, the first McKesson contract is for just like general pharmaceutical distribution. So the inflation cost was like 15%. And
Correct.
The other is for specialty drugs, and the inflation factor is a whopping 40%.
Right,
Yeah.
for plasma and biologics. I'll let.
Okay,
I'll let,
so I think that it's really important to get some of these numbers on record, to be clearer, just so the public can follow. For instance, I think that it will be helpful to know that how much of the actual contract goes to the purchasing of goes to the drugs, and how much of it actually goes to McKesson for the distribution service.
Right. So the amount that we pay, the McKesson receives a very, very a minuscule portion compared to this amount. Almost all of the actual money that is spent, 99.9%, is for the paying for the drugs themselves. And that's across both of the contracts, plasma and biologics, and the other ones. Most of how McKesson actually gets money is through this bulk purchasing that they have with the manufacturers.
It's just kind of scary to see that we're crossing the $1 billion threshold. So it's not just the Powerball and the Mega Million. We did too.
I agree.
I
Yeah,
totally agree.
That's the slides.
Yeah, and I think that, it also reflects general sentiments on how costly medications are going into. So do you have like a figure estimating like how much of our uninsured patients require specialty drugs versus those that can be reimbursed?
That's a great question. I don't have the exact number. Our overall percentage of uninsured patients is below 30% within the health network. How many of those specifically get specialty medications? I don't believe is significantly different than the general population, only because we don't provide inequitable care to those without insurance. Rather, we try and push them and help them with social workers to get enrolled in programs like Medi-Cal. That being said, also they tend, when they're going to see specialty providers in oncology and other places, that's when we really try and bring more support in terms of getting Medi-Cal to them. So overall, our system as a whole spends over 50% of our drug budget on specialty medication. But what we've done is actually try to do as much of that in-house because it allows us to utilize the cheapest purchase power rather than going outside of our system, if that makes sense, utilizing the 340B drug discount. So in that sense, we are well poised to try and pay for those specialty medications for those who don't have insurance.
Okay, so yeah, so I think that it's best to like have that also included in the notes. That way, because it's crossing the $1 billion, I think that we need to like be a little bit even more transparent in terms of like what's causing the increase. You know, it's not just 100% increase. It's like over 100% increase per year.
Right.
Thank you.
Okay,
Commissioner Chung, may I ask some questions that Commissioner Chow forwarded to me before?
of course,
Yeah.
please do.
And Commissioner Chow, by the way, sorry he can't be here, but he's got some physical illness stuff going on. So if the 340B program is in jeopardy next year due to who is elected president, Commissioner Chow wanted to know, does that jeopardize or would that change the formulas that went into this contract? He knows that the contract will run out likely before that all happens, but he didn't know politically if that is any issue that we should be concerned about.
Right now, we, in discussion with our national advocates for the 340B program, getting rid of the program altogether during the course of this contract does not seem to be on the table. It is currently actually there's lots of litigation in the courts. It's actually going to the Supreme Court now in terms of the restrictions that are being placed by manufacturers. So there has been no discussion that the program as a whole will be tanked. So that hasn't been part of the discussion around the budgeting for this process.
Thank you. That's good news for everybody all around, right? And so he was concerned. He knows that you all manage money well, the budget well as the pharmacy. But again, for the record, because he was thinking the public may really jump at this number or the press, and he wanted to have this on the record to explain how reimbursement works, although you had a slide on it. He was concerned that the public may think that this chunk of money is going to come out of our budget and then we'll be held accountable for that. But it sounds like the drugs are ordered as needed. But could you explain and go into the weeds a little bit about how this works so that the folks who don't know anything about this can understand how the money flows along with the drug purchases?
Yes, absolutely. I'll preface that before and say that the budget authority for which we're asking, we anticipate is much greater than what we will actually use. We're trying to bake in a large buffer to take into account unexpected things like a COVID pandemic, monkeypox, and to make sure that we can, if there is a gap between reimbursement and purchasing in situations, emergency situations like that, we will have the buffer to do that. Also, there are new treatments that have recently been approved that are incredibly expensive. As much as $3 million for a single dose. Now, that scares me significantly, and it would be one that probably wouldn't be given unless there was insurance, so that we would get reimbursed at or above the cost of the drug. In terms of the overall purchase and reimbursement process, whether or not anytime a drug is given, whether it's in the acute inpatient setting or in an outpatient clinic, like an infusion center, if you are getting infusions for cancer treatment, or an injection for rheumatoid arthritis or autoimmune disease, we submit that to the insurance company. And generally, before we ever approve giving that medication, we know exactly whether or not we will get reimbursed for it or not. And so the majority, over 70% of people in the health network have some sort of insurance, either Medicare or Medi-Cal. And we make sure that the reimbursement that comes in is at or above the cost of the medication. So even though, let's say, we may spend $1 million in a given month, we may get reimbursed of that $1 million. So we actually would not lose money, and the reimbursement would come from those that have insurance. So even if the cost of the medication is high, we know we'll get reimbursed at least at that level. That's going to take place whether it's in the clinic or in the hospital. What we do is then that money goes back into the general fund so that in the long run, even though we're spending more and more on these specialty medications, the reimbursement for these specialty medications is also going up. So even though our overall spend may increase 30% per year, our reimbursement should be increasing at the same amount. If there's a time when we know that reimbursement won't happen, we call it that insurance company simply won't cover it, then we take a very hard look about whether or not we'll make that drug available to anyone, whether that's someone who has no insurance or someone who has insurance. And our goal is to try and provide the same level of medication for our uninsured patients as those that are on Medi-Cal, which is kind of considered a baseline. And we hope that uninsured patients will only be uninsured for a short amount of time.
Thank you. And then one final question. I really appreciate that you're going. Commissioner, is this okay? That
Yeah, so I have follow-up questions to that too. So in terms of the reimbursement, do we also get reimbursed for, like paying McKesson for the purchasing and distribution service, or how do you calculate what to bill for reimbursement?
So the reimbursement is actually not, McKesson is not part in the reimbursement circle in any way, shape, or form. So that is completely between the insurance companies and DPH. So McKesson is completely removed from that, and they don't see any of that money in any way.
Yeah, so it would be really helpful to know exactly how much McKesson get, aside from like all the money that goes into purchasing the medications, because like there's no indication like how that is breaking up like for both contracts. So the first one is, it's okay, it hasn't crossed that $1 billion threshold, but but then really, like when we cross that threshold, we really need to be able to get ready to answer to any questions the public have.
And Commissioner, may I offer a suggestion? Because it sounds like that data is not readily available. But Dave, would it be, or Dr. Smith, would it be too much work, or would it be a burden to gather data on a quarterly basis to report back on that, like the percentage of what McKesson gets per quarter based on the cost of medications and then what McKesson's actually getting paid, so that the commission and public can kind of see what this is actually costing?
Yes, we can absolutely work through that.
Commissioner, would that suffice?
That would be really helpful. I just want to make one more comment is, I'm involved with global health policy. So like when I see these numbers and see how big of a difference, and how much privilege we are in a country that can afford these kind of medications while the rest of the world cannot, it kind of breaks my heart. So that's why, like to me, I pay really close attention to that.
Absolutely.
Thank you.
All right, thank you. And so is it okay to move on to the next? Okay, thank you so much for your explanations and thorough responses to the questions.
Thank you, Commissioner.
Thank you, Dave. Okay, contract number 4 with Instituto Familia de la Raza. It's a VHS contract. Requested action is the approval of a new grant agreement with Instituto Familia de la Raza, contract ID number 10000028957, for a total contract amount with contingency of $1,250,970 for a contract term of July 1, 23 to 6/30/2028 for 5 years. While this is a new contract, it is for continuing services which were previously approved at the June 5th, 2019 Health Commission meeting under contract ID 10000111456. The contract is for this agency's MHSA PEI school-based youth-centered wellness program. This program provides school-based wellness to low-performing students who are experiencing school difficulties due to trauma, immigration stress, poverty, and family dysfunction. The department is requesting the approval of this, secured through a new solicitation, which has been previously based on the contract for the same services with the same provider, which was previously reviewed and approved by the Health Commission. Total amount with contingency is stated as $1,250,970. If you have any programmatic questions, Min Tam, who's the director of the school-based mental health services and the children, youth, and family system of care, is attending virtually and can respond to any programmatic questions related to this contract.
I don't have questions for this contract. After those like big numbers.
Everything else seems different in contrast, right? Okay, item number 5. It's a contract with AGFA Healthcare Corporation for the San Francisco Health Network. The requested action is the approval of a new contract with an existing vendor for the same services. AGFA Healthcare Corporation has been DPH's picture archiving and communication system vendor since the year 2004 and was last sourced through Vizient, the department's group purchasing organization. In 2023, AGFA Healthcare Corporation separated from Vizient, removing the department's existing purchase authority. Due to the prior infrastructure investments, the department will procure the new contract term authorized through sole source 21.30 software and maintenance and 21.5B equipment lease. The total contract amount with contingency is $8,364,139 with a proposed initial term of October 1st, 2023 through September 30th, 2028 for 5 years. The Health Commission previously approved the prior contract on April 7th, 2015. The prior contracts were organized into 3 separate agreements: equipment lease, equipment maintenance, and software maintenance. The new contract will be organized into 2 agreements: equipment lease and software license, software maintenance, and equipment merged into one. The change in the total contract amount of $5,770,589 is due to the difference in the contract length, with the previous contract having a term of 8.5 years and the new contract with a term of 5 years. Should you have any programmatic questions about the functioning of this contract and its services, we have RJ Merck, who's the imaging supervisor with DPH, attending virtually, who can respond.
I don't have any questions for this one either. Consider how the annual differences is like less than 1%. Like, what am I supposed to ask?
Well, Commissioner Shao did have one quick question.
Okay.
He asked if the if photos are archived, if there's a time limit of how long we keep those data. Not related to the contract amount. He just was curious.
We have RJ on the meeting.
Yes, RJ, I will unmute you. RJ, can you hear me?
I'm here.
Hi. Did you hear that question?
Yes, I did. We don't delete and purge prior imaging at Zuckerberg. Most hospitals don't. I think for 2 main reasons. One of them for us is we're also a research hospital connected with UCSF as a teaching hospital, and so that imaging is kept forever. But the other reason is, as everyone knows, Moore's Law, imaging gets denser and denser, stored for cheaper and cheaper. So we end up getting the same amount of servers to store stuff Even though we keep continuing adding imaging, we don't really need to purge stuff. Does that answer the question?
Yes, thank you so much. I'll note that for the record.
California
that
law
it's-
is 7 years, I believe.
Oh, I'm sorry, say that again?
California mandates you keep things for 7 years
Okay.
with a couple exclusions, but we keep stuff forever.
Okay.
I think that it's also because we're dating ourselves, like back in the days when everything get warehoused. So I guess, it's a new world. We don't have to do that anymore with the advance of technology. So, which is wonderful to know.
Great news.
And it's funny you bring that up because this month we finally got rid of our last piece of film in a warehouse and are no longer paying that storage.
Hey, we're saving money there. That's good. Thank you.
Wonderful. And as I noted earlier, because we don't have quorum for the meeting, the vote cannot take place until Commissioner Guillermo comes on. But thank you so much for everyone who presented and who answered questions. I think we can move on, Commissioner, if you're okay with the 2 new contract requests.
Yes, please.
All right, so let's move on to the Mosmatech contract. Please.
Good afternoon, Commissioner. Okay, so Behavioral Health Services has contracted with Mosmatech to conduct bed optimization analysis for behavioral health services beds. And the report is hopefully going to gain some insight as to how we're using our current behavioral health services beds and maybe suggest ways that we can improve our usage of the level of care for the identified beds for the project. So what we're requesting, the current contract is $89,600. We've exceeded that threshold because the work had to continue into the next fiscal year. So we're requesting an additional $20,000, which would bring the contract to $109,600.
Thanks. Any questions, Commissioner?
Not from me. Thank you.
Yeah, I did not get any from Commissioner Chow on this.
Okay. So when Commissioner Guillermo gets here, we'll add this to the vote package.
Sure, great, thank you.
Thank you. All right, we can move on to the next item, which would be item 5 on the agenda, a request for a new grant agreement with Richmond Area Multi-Services. Oh, and can you, because the microphone is that, yes, please, thank you. Yeah, just so that it'll capture your voice.
No problem. All right. Good afternoon, Commissioner and Mark. I'm glad to be here. My name is Krista Gata. I'm the Director of Strategic Initiatives for the Population Behavioral Health section of the Behavioral Services. I am here to present the Best Neighborhoods Clinical Sole Source Grant Solicitation Waiver Contract with Richmond Area Multi-Services, or RAMS. I think I am joined today by Angela Tang, who is the president and CEO of RAMS, and we're both here to answer any questions that you may have. So last month I was here and I presented the peer portion of this contract, which RAMS also holds, and I'm really thrilled to be here to present the really critical clinical portion of this multidisciplinary team. As a reminder, Best Neighborhoods is BHS's primary street-based outreach team. The team works in assigned neighborhoods 5 to 7 days a week, providing outreach to identified hotspots where folks with a lot of needs are, and also identifies and follows up with folks with acute behavioral health conditions who are experiencing significant distress in the community. The Best Neighborhoods team is highly collaborative across city street response teams and is extremely focused and accountable for trying to stabilize and transition clients into long-term care and services. The team is comprised of peers of lived experience, health workers, and we now are excited to add mental health clinicians. The team also works with a part-time street-based psychiatrist and registered nurse. This part of the contract, the mental health clinicians will provide street-based psychosocial assessments, including assessments for involuntary 5150 holds. Based on these assessments, clinicians will work with DPH clinical staff to develop comprehensive care plans with concrete action steps that are reviewed at least weekly in a DPH-led multidisciplinary multi-agency care conference. Clinicians will chart work in Epic and support peers in documenting general outreach work in MS Forms. And I'm happy to take any questions that you have.
And it's not so much about the contract itself. So I think that this is an ongoing questions that we've been asking, like what exactly does impact looks like for, the dollars that we invested, in these interventions. And I think that it helps, like if we can like get some of that.
What the, yeah. So what I can tell you now, I mean, I don't need to tell anybody, we've got a lot going on the streets. We got a lot of folks who are in need, who are unhoused, who are experiencing significant mental illness, substance use disorder, and without intensive focused outreach are not getting indoors and getting the care that they need. In March 2023, DPH reorganized our behavioral health street outreach team. So we had 3 different teams that we put together. One was called the Behavioral Health Homeless Team. One was the Street Crisis Response Team, which had clinicians on the rigs, and the other was a peer contract with the Felton Institute. What we were seeing was that our folks were spread thin across the city. We're only able to do 1 or a couple touches with folks, and we weren't seeing a lot of progress with people. When we noticed that and we started to really think about it, we did a pilot in the Castro neighborhood where we put the same people in the neighborhood every single day. We identified what we call, you probably remember the shared priority pilot. There was the HUMS and there was a housing referral. We took the best of that approach and said, why don't we do this more on an ongoing basis with the people in this neighborhood? Then we said, let's take the best of HSOC, the multi-departmental approach. Let's pull in all the different departments who work in the streets and let's coordinate and meet regularly. Within several months, we saw more progress with folks than we had seen in years. We had been there for years. I'm not saying folks move indoors and move in to care. But with this very intensive approach, we started to see results. And so we thought, well, I think this works. Let's reorganize everything. And so our distinct goal is to get to know people in neighborhoods who are the most acute, the most at risk for utilizing our street crisis response team, hospitals, our jail system, to wrap around them intensively with an everyday approach. There's a lot of case management programs that are once a week, and we realize that's not enough for many of the folks that we're working with. Pair it with multidisciplinary folks, so peers who can really do engagement, health workers who can do real system navigation, and clinicians who can really do that deeper psychosocial assessment and can initiate 5150 holds, work with psychiatrists to actually recommend folks for conservatorship, care court, et cetera. And we have started to see an incredible amount of success with that program. So what I'm trying with this, we have some general outreach data that we are collecting, but I'm very excited for us to be charting more in Epic so that we can start to see more longitudinal outcomes with clients. And if we do our job really well, although we always need places to bring people, we will start to see a noticeable difference on the street and an improvement in these folks' health.
So you start reorganizing the whole interventions after March, right?
Yes, so we
So-
implemented this in March.
So Mark, do you think that we can have them come back to the Population Health Committee, like next March to do a presentation? So you would have some data to tell us the fullest stories. And
Yeah, I
we
would.
love stories.
Oh, well, I love telling stories.
Good.
So we would welcome the opportunity to come back. And I'm really excited because RAMS is going to be providing both the peer work and the clinical work along with civil service providers. So I think that by that time, I'm looking up at both of you, Angela and Hasyan, that we'll have a lot more to report at that time.
Sounds great.
Awesome. Thank
Thank
you so
you.
much.
And if I may, Commissioner Gerardo, who's not here, asked me to ask you and she's asking, not suggesting, would the model be helped by having mental health interns so that you have more people and that you're training a pipeline? She's really into pipelines.
Yeah.
And but she knows that this is really intense services, and she didn't know if if it made sense, but she wanted to offer that.
I would, I think that many of the clinicians that we are seeing are newer in their careers. And one of the things that I do really respect about RANDS, and I'll also like hand it over to them, is that they are very committed to training and supporting folks in the work. And so I would say for this particular program that there would be openness to doing that. It's certainly something we could support, given that between DPH and RANDS, I think we would have a robust enough support system to help folks in the work. But Angela, Hassan, do you have anything else to add to that?
Good afternoon. Just wanted to echo that, RANDS is really committed to kind of training the next generation. We're celebrating our nearly 50 years next year, and really from the very beginning, we've been about workforce development and having internships and a variety of different clinical internships and peer internships. So to support that workforce development.
So we'll take that suggestion back, and certainly maybe when we come back in March, we can talk more about whether that's something we can.
Sure. And I am horrible with names, but Ryan in BHS coordinates the internship pipeline. I forgot his last name, starts with an F, but he would be the person on the inside, and I'll email you after the meeting. Yeah. Okay, great. Yes, right. Oh, thank you. Could you say that? Thank you.
Okay, absolutely. We will
Right.
contact Ryan.
Thank you. And welcome, Commissioner Guillermo. So at this time, could you have a seat for a second? Thank you. We can, if Commissioner Chung would like to call the formal meeting to order, we can do some procedural things and then go back to the items we've already discussed.
Sounds good. Then would you please
Oh, call the roll?
call the
Yes, Commissioner Chung
here,
and Commissioner Guillermo.
present?
I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the agenda is the approval of the September 5th, 2023 committee meeting minutes.
Move to approve. I second.
And there's no one on the public comment line, so you all can call a vote.
So all in favor, say aye.
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 Great, thank you. And then Commissioner Guillermo, Commissioner Chung went through items 3, 4, and 5, which were all the contract items. So we can go through for a vote, but you are certainly welcome to add comments or questions if you have any as we go through. We can go back to the monthly contracts report.
Oh, and FYI, Commissioner Guillermo, we are pulling the last contract from the contract report out, like to get some alignment with, the current like budgets, and it will come back to us next month for approval. Okay, that's the health advocate contract. Got it. Thank you.
So Commissioner, do you have any questions about, or would you like to discuss any of the things from the contracts report before you all move into the vote?
Oh, none from the contract report. Thank you.
Okay, great. So Commissioner Chung, or can you two do your motions and then vote so that we get that on the
Okay.
record?
So we need a motion to add this to the consent calendar for the commission approval.
I move the recommendation of approval of the contracts report to the full commission.
And I second.
So all those in favor?
Aye.
And Commissioner Guillermo, in the notes from this meeting, you'll see there was a lot of discussion of the two McKesson contracts, which are really expensive, but there's good explanation for it. Commissioner Chung can answer questions, I think, at the full commission meeting. Item 4 is the request for approval of, I actually have forgotten how to pronounce the name, Mosumtech? Yes. And so that again was already discussed. There's no one in the public comment line. You all can discuss or ask questions or move to approve or move to recommend for the consent calendar.
Can we entertain a motion to add that to the consent calendar for the commission approval?
Yes, move the recommendation.
I second.
All those in favor?
Aye.
Aye.
Oh, great. Thank you. And then item 5 is a new grant agreement with RAMPS. And again, it was discussed, but you're welcome to ask questions or comments, make comments if you would like before motions are made.
Okay.
Okay.
Did you already have questions?
Yeah, so I think that the main questions I have is, like what makes this, how do we see impact in these kind of investment? And Krista was like kind enough to like share a story with us, like how they restructure the intervention. And I have requested them to come back to the Population Health Committee next March, to give us, like a presentations on how it has been transformed.
I think my question had to do with just sufficient staffing for the programs. It requires a lot of specialized, I guess, skills. I'm not sure, I mean, just knowing how difficult it is to recruit talented and skilled folks to these types of programs.
Yeah, that's a great question and something we, along with our other street team partners, struggle with at this point. So the two primary contracted services are peers, and then the second one being mental health clinicians. I think we are about 75% staffed on the peer side of it. This will be a new contract with RAMS. They might be able to talk a little bit more about it, but it has been a challenge across our system to recruit behavioral health, especially licensed clinicians, and in particular for street-based work.
Yeah.
One of the things I think I said earlier is one of the reasons I really like to partner with RAMS is their investment in workforce development. The level of training and support that they provide was very attractive to us because it's the work. One, it's really hard to get folks to come and feel supported in any of this work, but in particular on the streets, there's just such a high level of burnout. So we struggled with this with our past contractor with hiring enough folks. And so, Angela, I'm not sure if you could maybe provide a little more insight into how you guys are feeling going into this contract with the behavioral health clinicians.
Hi again. So I think for agency-wide, we have you can see many different contracts with the Department of Public Health. We have an HR department and very plugged in with a lot of the schools and different ways in which we do recruitment. It is tough, like Krista was saying, that it's a system-wide, but also just like national type of dilemma that we're having. So I think on the workforce development, every year across the agency, we have nearly 30 interns. And a variety of different staff at different levels. Hasyan, would you like to add anything specific about this program?
Sure, thanks, Angela. Yes, I can speak a little bit more some of our plans internally. So to talk about the peer piece to get 100% staff, again, to Angela's comment, we do have a pipeline of training and internship and a very large peer community, counseling community, and that's how we usually start our recruitment. And for the clinician piece, yes, we understand the challenges that's going to come with the recruitment. Again, we're going to leverage our partnerships, our relationships internally and externally to see if we can, have some people who are very interested and qualified to hopefully apply and feel fulfilled in the work as well as contribute towards the objectives of the work. So we know we have our work cut out for us, but we're very optimistic that we can work together with DPH in terms of strategies and how we can work together to do some outreach and effective outreach.
Okay.
I would just, in terms of what is going to be reported or shared at the Community Health Committee, that the issue of staffing and how that's impacting the progress and the success of the program, because we'd want to make sure that we're not overburdening an organization with expectations and objectives if the staffing is really going to be that much more problematic in the future, because otherwise it just becomes much more difficult to manage, not just internally, I think, from the provider's point of view, but in terms of the clients and as well as the public's perception
Yeah.
of where the problem lies.
That makes a lot of sense. And so currently, we have an aspirational plan to have like 5 different neighborhood-based teams, situated in various areas of the city. And at this point, we've only launched 2, given that it would be impractical and unreasonable for us to say you need to be all over the city. So really focusing in the Tenderloin and the Soma area and the Mission and the Castros or Fillmore area. So I think that is part of our plan, is to be very clear and transparent about what area we can cover, how many clients we can take in our what we call shared priority caseloads. And so we are continually fluctuating and adjusting based on the number of staff. So that, I think one of the things you didn't hear what I said was what I noticed when I first came in, I was asked to take a look at our teams about a year ago, is that I had smaller number of people and they were just citywide and they would just go they had to go everywhere. And so what I was seeing was they were just kind of one-touching folk and we couldn't see a lot of progress. And so knowing that we're not going to make the impact that we want to see. So it was better for us to shrink geography, shrink our client size to make greater impact with fewer folks. So certainly that'll be part of our planning and we'll scale as staffing is available.
I look forward to hearing more about how that approach is
Yeah,
making an
absolutely.
impact. And yeah, thank you.
All right, thank you.
And can we have a
Yeah,
motion?
so I'll make a motion to approve and recommend.
Okay. And I second.
And all in favor?
Aye.
All right, great. Thank you so much. We can move on to item 6, which is the Finance and Planning Committee calendar planning. And I can do a quick introduction and then turn it over to Commissioner Chung. This item came about from various comments made by the commission members over a period of the past year at different meetings where you all were requesting various things to the department. This is your time to kind of dig in. This can come back. This is an item that we can repeat over and over, but this is like the beginning of maybe planning for next year and seeing what items you'd like to calendar kind of on the meta level. So please feel free to ask questions. Ms. Ruggles, we thank you for your work on the presentation she gave just to help prep you all. And then I included the sheet on what contracts go before the commission and the board so that you all can have that as a guide as well.
Okay. Well, thank you, Mark. And yeah, so part of how this originated was because of not recent years, like when I first got appointed to the commission, like over a decade ago, there were like some changes in some of the organization. Some of them closed for business and others, like picked up their contracts and have been going on and carried those contracts, till now. So the question is, like, and it's a very business model, but it's a very for-profit business model, that, there were mergers and there were all these takeovers and, but we don't really know, like how, to what extent, like we're investing in these organizations or partner with these organizations for services. So the question comes up because we had seen in the past that we have contracts with, like traditional partners, like who were not able to like continue to manage the fiscal responsibility and ended up like have to close their door. And at the same time, we were still like entering into new contracts with them. So we hope that, we can start some of these conversations, to make sure that we can have more accountability of how we partner with organizations and also trying to see the crystal ball before disaster happen and, and provide necessary support for these smaller organizations so that it doesn't go through the same thing again, because I think that there's value to smaller organizations because they're more community-based. And, and so if we can actually support them to, stay open, like maybe there would be more positive impact to our clients and, like our target audience. So how do we do this, Mark?
So this is kind of a brainstorming session. This is not where you all would dive in and have the discussion. You certainly might have a little bit of back and forth, but because topics haven't been noticed, this wouldn't be the time to actually dive in. So you all can identify and talk to Ms. Ruggles will kind of be the lead here, but there's other staff to support her, that you all can ask for items to be calendared in the future. So I'll just note that a few things that have been repeated in meetings are your concern, and then of course, the floor is yours. Your concern with quote unquote mega contracts are too big to fail, about how the DPH is choosing them, how they're monitoring not only the fiscal side, but the model of their services and the use of them in their service category. And then you've had repeated questions around client outcomes and how a specific provider and contract are actually going to impact a population. Those are the two things that I've heard over and over again, but those are the kinds of things that you could say today where you could, ask for that as a presentation in the future, or Ms. Ruggles could remind you that that's part of a routine report she might give or something she's already done, so that you all can come up with some items for the next calendar year. And also Ms. Ruggles is here to suggest things as well that she's heard. Mr. Goodwin too. I mean, this is kind of a free-for-all for just idea sharing.
Well, thank you, Commissioner Guillermo.
Thank you, and I appreciate the work, and I appreciate, Mark, you providing this putting this on the calendar for us. And it's hard to, I think, pinpoint the exact agenda items that might relate to the questions I think that we've been posing over the last years. And especially since things are so dynamic in San Francisco around, the kind of services that are needed and the kinds of organizations that are required to address programmatically a lot of the sort of mandated programs that we had, both in terms of the funding sources that we get, as well as our own budget that we put into it. So I do think, there's a big picture approach to this, as well as Commissioner Chung has mentioned, there's sort of a deep dive into sort of the details of how particularly a smaller or mid-sized provider can be, part of the overall network of services provision and be impactful, even to the extent that they might not be fully fiscally or organizationally sound, right? And where does the department come in to assist with that? I think one of the questions one of the concerns that we have expressed is we really want to make sure that the service providers that we are contracting with are in a good position to both be responsible for the resources that are that they are receiving from the city and county, but at the same time able to have some flexibility in the way that they provide services based on that dynamic that happens in San Francisco. So as I said, it's very difficult to sort of pinpoint the exact agenda items, but let me try to do at least one thing. So a lot of the materials that you provided, and I thank you again, really focus on the business operations aspect of nonprofits, right? Which is really important. If you can't function, then they can't provide the services. But I'm looking to see where does the intersection between the financial and operational stability of an organization relate to the programmatic delivery, right? So staffing is an example of one of those, right? The question I asked earlier for the earlier contract. So there is a monitoring of sort of budget and personnel policies and such. Are you spending things the right way according to the budget? But if the spend can't match up with how the budget is presented, particularly as it relates, for example, to staffing, right? Then how do we flex around the ability to either move those dollars somewhere else, right? And I think it's easier with a larger organization, and sometimes maybe that's why some of these mega contracts happen. versus a smaller organization. So it's just sort of that, that intersection, that dynamic play between the execution of a contract and the spend of a budget and the monitoring of it as it relates to the range of service providers that we contract with. It's easier, I think, to flex with mega contracts in some ways, just because there's just a larger operational structure, but it's harder with smaller ones. And
Yeah,
so,
it
yeah.
also it also comes back to quality
Right.
control.
And that's why I worry about, because it's easier with the mega contracts, it's easier to just say, okay, they'll figure it out. And so maybe we take our hands off of that a little bit too much, right?
Yeah.
And I'm not sure if that's the case. It just sort of, logically feels that way. And, bigger organizations can manage, internally, they can move things around. So, and they can, they can manage a lot more. So I don't know how much that comes into play in the consideration of contracts. But if there is not an ability to sort of intersect that operational functionality with the programmatic delivery, then you can easily miss the quality and the impact.
Yeah, and I just want to add, like one thing that we did requested to change was that, if there are like new contracts with an existing partner, and if the existing partner is going through some corrective action, it would be included, like in the contract report for us to look at. So, that is like slowly evolved into a more comprehensive reporting system. But I think that's the questions that we still need to answer. How do we preserve the original culture of like these organizations providing population-specific services? And I don't think that anybody has an answer right now at this moment, but it's something for us to think through.
One of the other questions, maybe, I don't know if it's related to this or directly, but as the consolidation of the monitoring has happened across the city, right? So part of the overall controller's office monitoring, right? As described.
Fiscal monitoring, yeah.
Right. Does that make it easier or harder to quickly intervene in an organization that's encountering operational or financial or governance problems? Is the bureaucracy does that make it easier within the bureaucracy or harder?
It streamlined it. Yeah, I think what it did was it streamlined the process. The vendors were getting asked the same things by all the different departments, and it's also built up teams. And so the staff that are on the fiscal side, I have Wasim Samaras here from BOCC on the fiscal side, and then Jorna Reyes is our new BOCC director. Yay. But by having that, there's built up relationships. So a lot of times when there's an issue, we pull in our city partners to talk about it and resolve it, knowing that DPH isn't standing on its own with a vendor, or if we aren't standing on our own, then we need to make sure it's coordinated. So I think that's been a good part about it. It's standard. The controller's office has done trainings with the CBOs. So I think that hasn't built up more bureaucracy. They're looking right now at trying to do some sort of standardization with the programmatic side. And it's, I'm not 100% clear as I stand here without having checked. I think the standardization is making sure that all the city departments have standards for programmatic monitoring. We do. So we have, right, room for improvement, but we have standards and there's a process in the whole monitoring. So that part's happening. I was thinking, oh, go ahead. I didn't.
Well, so I mean, that's good to hear. Has that, if the bureaucracy hasn't been an impediment, it's actually been, a good thing. Does that change the timeline in terms of how you're identifying problems and then being able to do the, the problem solving or interventions? Have you monitored or tried to measure the time that it takes to be able to identify uh, and, you know,
There's two
fixes?
parts, which may be confusing in all the papers, but there's the annual review of the audited financial statements, and that's based on them submitting them, and that's done by DPA. So there's a lot of flags that are there, like cash flow and cash on hand, and I don't know all the terms, but so that happens annually on our time regardless. Then there's the citywide fiscal and compliance monitoring, so that follows a schedule. There's also flags that come up during the year, and in there we've designed a form that we've started. It's not across all our contracts yet, that we want to have the financial stability report, which is where we would capture warning flags. So a warning flag might be, with our contract, we can't make payroll, we don't have invoices. So then it starts to, like that example's on it, oh, you don't have your contract or your invoices, but it starts to raise red flags. And so there's a lot of places in the system where we're touching and those flags come in. If a vendor, there's a form in here, but if the vendor, for example, asks, let's say they owed money back as a result of whatever, like an audit or something, our own internal audit, and they owed back money. So if they're not able to repay on the payment plan that was established, so those are the kinds of flags that we're trying to pull together on a single place on one document so that that information is available. The other piece on that not to highlight because we haven't done it, but we wanted to restart. It's this monthly committee that we held regularly before the pandemic, and it hasn't really picked back up, but it's an opportunity to bring problem agency or agencies where we have concerns into a monthly group that brings together all the individuals to talk about and the strategies. So while that hasn't not happened, if you think of like the Baker PRC, there was lots of meetings that happened without, I mean, they established their own formal regular meetings on that topic. But so that's one of the things that we're trying to do. So one was the form, which is multi-page to collect warnings, programmatic, fiscal, and then this meeting. So one of the things that's like within my realm and that when you had talked about is the too big to fail contracts, but it also could be the too small to like, whatever the criteria is.
Function, yeah.
Too small to fail or too specific, like we'd be really in a bind or whatever the criteria is, then we could come back and present on those contracts. I just wasn't sure from some of the questions how to like dig down, like too big to fail. So what are we showing you that's different than our other monitoring? So we're open to whatever you want. I think that the other question you've asked about is, what are we monitoring programmatically and do we know if it's making a difference? And so the Business Office of Contract Compliance, BOCC, monitors the performance objectives that are provided. Those are developed on the program side. So that I think would be like a behavioral health services or whatever area to look at. And that might be another interesting topic that could be, an ongoing and looking at areas of how the objectives are chosen.
It's the intersection of those two things though, right? So how does the contract compliance with regard to, budget, finances, operations impact or not impact the program delivery, right? And again, the example that I always think of is staffing. If you can't get the right staff or any staff, right? Is there, and that impacts program. But on the budget side, what it might show is they're not spending the money, right? Or they're asking for additional dollars in personnel because you have to incentivize, right? Or you have to, change from an employee budget to a contract budget or something, budgeted item. Those are the things that I think might give a bigger picture, right? Than monitoring separately the programmatic deliverables and the operational financial, compliance. So, and I just don't know whether that happens. And if it does, how do we find out about that, right? In terms of a report.
Yeah, these are like kind of like sound like accounting questions as well, but like I gave all my managerial accounting like knowledge back to the professor the day I graduated. So, but I think that that's really, part of it is, like sometimes we overlook, the balance between their assets and their liabilities. And even for too big to fail, like we're not the United States of America, so we don't have the luxury of keep raising the debt ceiling. So, and so that would be something that we like to like take a deeper dive if possible, like when we are considering bid, how do we put weights into looking at their accounting structure and also, like their asset versus liability. Does that make sense?
It makes sense. I'm not sure how to translate it.
I think that has a lot, to me, that applies a lot more to the sort of too big to fail, because if you look at a balance sheet for an organization like that, it's going to be much more complicated, right? They may have debt, they may not, they may have, some other kind of cash flow, processes or, different ways of spending in different categories. And they may have funding from multiple sources that they have to account for that has nothing to do with the city, right? And so that's something that we don't necessarily get, I think, because the focus is on how city contracts.
Didn't we used to also provide technical assistance to some of these like organizations that, like need some type of like corrections of improvement?
Yeah, the contract right now is through the controller. But so, right, but we work with them. So if we have an agency that needs X, then that gets worked through with them. But we actually are working on designing a solicitation that will for technical assistance. And I think it's in the beginning steps of figuring out what is it that we want to offer. We were going to try to piggyback on with another city department that was doing that, but it didn't work out. So we're looking to do our own. Probably the financial piece will likely stay with the controller, with their consultant that gets assigned to help, but you have more on that. Is there any? Yeah. So you want to talk about technical assistance?
Oh, sure.
Contracts.
Sure.
Controller.
Yeah, so basically when we do the fiscal and compliance monitoring, and if we identify any agency with any like weaknesses or they're struggling, or if they don't have sufficient or effective enough like policies and procedures, then we can refer them to the technical assistance that is handled by the controller's office. And it's not it's a very quick form. We just tell the controller's office this agency is in need of assistance. We identify the assistance. They set up a meeting with their consultant and the agency, and they kind of go through a plan kind of that they just write out the plan, and we have regular check-ins to see how it's going. And it can also be that the agency itself reaches out. So without us identifying somebody in need, we also encourage agencies that they come forward if they need help, and they can request the technical assistance. And obviously, it all depends on if the controls office have enough budget. But I think so far I haven't experienced any time where there wasn't enough budget with the controllers to offer the assistance. I think pretty much all agencies that we either referred or they come forth, they've received some technical assistance through the controls office.
So I'm trying to get back to maybe presentation, the item about future presentations on mega contracts. Do you know offhand, and maybe there's something that can be reported, in the form of a report, these mega contracts or these organizations that have mega contracts, my assumption is that we are not their primary funder, right? That organizations of a particular size are going to have federal contracts, philanthropic contracts, city contracts, maybe multiple, county contracts. Is there a way to maybe report on mega contractors or vendors that have a certain percentage of funding that just comes from the city relative to all their other funding? And might that be some indication of where there might be, or you predictive thing about where there might be some issues, because it may not be the city funding that's causing a problem, it could be other funding, or they might have staffing that is funded by multiple contracts from various sources. I mean, it's getting into the weeds a little bit in terms of, how these mega contractors might be managing their budget and their financial stability overall. But I'm just making that assumption that these vendors and contractors that are mega contractors with the city, or mega vendors, whichever terminology is correct, might have a much more complex financial situation than what we might be seeing.
What we have, it's only sort of helpful, but I did a breakdown of DPH, CBO contracts. We have 9 that are $11 million and over. And then 3 that are between 8 and 11 million, 7 between 6 and 8 million. I don't know what mega, like what the definition would be. The shortcoming in this is it's by contract. So some vendors have multiple contracts that would put them over. If you decided mega was 11 million, there might be some vendors, so a few more than 3 or 9, probably, that when you combine them, they're going to go over 11 million. So
I think that the way that I was thinking of, like the mega contract, is about like how many units of services they are performing, combined, like in terms of all their contracts. And, how do we track that to know that they're actually performing as, as proposed, without really duplicating any of that in their reporting. I mean, I have tons of tricky questions, but I think that that's part of like why we want to make sure that we know specifically, like how their reporting system works, like when it comes to compliance, and also, do they actually also send in lesson learned if they didn't meet their goals?
I don't think it comes in that exact format. The one thing is that the monitoring is done of individual programs. So the program, vendor might have 10 programs, but they're looked at individually. So it'd be like adding all the program information together. The form that I was talking about, that's by the vendor. So that was the place where we were bringing information into one place, across all the programs. The that one would be harder to figure out, or with our current system, it's going to be very manual to bring together those pieces. But if we looked at the megabyte units of service, but it's probably going to in some way break down to the amount of funding, right?
Yeah.
So
Can I ask, so if you were to articulate what you think is the concern that we might need to be paying more attention to around mega contracts, given your role and your experience over the years and your position, what is it that we need to be the most concerned about from your standpoint?
the thing that I'm most concerned about, and that I would like to get more routinized, is making sure that the results inform future contracts. And so in that same way, like the form, like if there's these red flags, I mean, they usually bubble up and the system works, but sometimes it doesn't. So I want to, and when I say doesn't, it means the red flag wasn't noticed or the pieces weren't put together. So that's what some of the attempts are with having a vendor, an agency, financial and programmatic stability, and having that meeting. So I don't know how to translate that either, but what I'm most concerned about is the feedback loops. And if funding is underspent, reallocating it. We are hoping to go out to RFP this month for a new, not just new, but we don't have one, what we're calling an electronic contract management system, which will be a place where we have lots and lots of data that will be immediately available. So if you asked a question, it would not be a 3-day research project asking, pulling it all together. We could just say, here's the units, here's this information. I think when we get that, and then it will allow us to track the contracts, where are they through the flow? It will also allow us to create some forms and then route them. So it's going to make a huge difference in contracting and then data availability to be able to check these things. So I don't want to say wait a year, but however long it will take to get that system in place and the data entered so we have it, then we will start to have data that will be much easier to roll up and to influence decisions. I think you're exactly right about underspending due to vacancies. And so the city's been trying to work on that too. That's something the controller's office has done with departments and community-based organization representatives. They did a survey trying to identify places, position class of types of clinicians that are vacant and underpaid, and doing some comparisons. And then the board and the mayor together created a 5% cost of doing business increase, but it's all along those same lines that our CBOs don't make enough money to fill their position. So, and then there's discussions about, well, maybe shrinking the system to pay more, and then you can keep your positions filled. So I'm not sure on the question too big to fail. I'm hearing some themes, but I guess if I were asking you to make an assignment that kept me on my toes, it would be to report back on how are we closing the loops so that the information travels through the system. And I think it would be having that meeting and, just that kind of outcome, like who's doing what, how are they doing, what did we find, what kinds of findings are we having?
Yeah, I think that it's really important to to bring up that we're not trying to catch anybody, like, but we really want to make sure that they are all successful, because then, like our clients and, benefits, like when they're successful. When they're not successful, like at the end, those who get harmed are the clients that we care about. So, and that's really the intention behind the question that we have.
Yeah, I would agree with Commissioner Chung so there's a big picture to this as well. And so I'm hoping maybe as you described this new system, data system, that not only will it identify, the areas where the feedback loop is sort of broken or needs to be tied up, but also being able to pull together large amounts of data, give a more strategic picture, and maybe some predictive information about what are the kinds of things that we need to sort of take a look at in order to sort of be a little bit, proactive in either providing technical assistance or making programmatic changes or changing the budget, those kinds of things, so that we're not stressing the organizations to catch up on things that they might not have themselves been able to identify. But with your help in this data system maybe, or some other kinds of eyes on, that we can really sort of help to strengthen. And because I know that's the goal also for the department, right? You want partners that are strong enough to be able to carry out, the services, and we want that for San Franciscans. So whether it's, addressing these feedback loops that can help in making good decisions about contracts and services and programmatic changes, or whether it's a big picture that's more strategic. Those are all the kinds of things that we probably need to move forward in a much more sort of proactive and positive way, particularly for mega contracts, but not just for mega contracts.
Yeah, hasn't been here for almost like 4 decades. I've seen how our legislative change led to closing of like a certain program. And then like what I heard afterward is that it was a substance abuse program, and people had to like be discharged, all the like residents has to be discharged. And then guess what, like within 3 days there were overdose already of these like discharged clients. So like, and that becomes a really important question for me, like, are those avoidable? Like, if so, like what exactly do we have in terms of like responsibility, like, so I'm not going to name the program, but yeah, so this is go way back, to when we first have the what's that called, the domestic partner equal benefits ordinance was adopted, like that, some of our contractors were not catching up right away, so we ended up like terminating those contracts, and which caused these kind of like ripple effects. And I just want to make sure that, when we look at giving like some of these large organizations, like more money that they can provide services to the people we care about, especially the most vulnerable, we want to make sure that there is a safety net, beyond that we can catch those who fall through the cracks. I mean, like what I would say too big to fail is, usually because of their size, they have a lot of different organizational structure, and there are more cookie cutter approach to things. There might be internal trainings, but it's all very standardized, like without really take a deeper dive into cultural humility, for instance, so, and we don't know exactly what type of workplace environment, like they actually have. So if we can do something and become the advocate, not just for the clients, but also for those who are providing services to the clients, then, I think that we then feel like we're doing our jobs. Like if we cannot do that, if we keep hearing like how toxic a workplace is and they still have to like work with clients, we know that how hard it is to provide health services. Like this whole COVID pandemic if there's nothing that it taught us, it taught us about, like self-care and like burnout prevention. So like, how do we actually translate that back to, like the businesses or the partners that we work with? I think that, that's part of public health too.
One of the other things that, particularly with mega contracts going to large organizations that are too big to fail, because there's the mega contracts that might not be with too big to fail organizations, and then there's the too big to fail organizations, right? My, again, an assumption is that the large organizations, particularly those who have experienced mergers or are part of mergers, or who have picked up contracts from another organization that might have failed, they've been around for a long time, right? So they have their own organizational bureaucracy, and their sort of entrenched cultures, right? So, and that goes from, the newest hire to all the way to governance, right? Board of directors and their practices. And I think I asked before, some questions about governance, and I know that you monitor that. But it might be that there is something about the way an organization is managed or how the management culture sort of permeates, as well as how governance and management relate to each other with regard to how operational culture is both developed and managed. And I don't know how that gets captured either, because it's not necessarily something that can be done in a form, right? But my assumption is that these organizations that have been around for a while, to the extent that they can attract mega contracts and they can be too big to fail, that there is something about the history of the development of that organization that might make it either more or less difficult to adapt, to change and adapt to challenge. So that would be something, it would be interesting to see how you might think about looking at, those aspects of an organization.
And by the way, I think that when we first talked about too big to fail, it was like a decade ago. That's when we start noticing, like some of these mergers happening. But with the contract report that we see today, like some contracts goes to $1 billion already, like, so that whole too big to fail might have a different definitions that we have to look at. But at the end of the day, it's about, like which of the contractors or vendors that we have relationship with have these like large amount, of contracts, and, like, and how do we ensure that the quality is up to par?
And when you say quality, you mean on the clients. I mean, obviously you two were talking about fiscal, but you're also really talking about client outcomes.
Yeah, because that's the impact that we want our investments go to. It's the public.
Right. Commissioner Chow in the past has asked, and I want to ask if you two are open to this, and if Ms. Ruggles can say if it's realistic, if for these large contracts, when there is maybe a report or you'll have a presentation, if the department can provide like a slice of pie saying this contractor has this big of a piece of pie of this service category, so that you all know not just the amount of budget, but also if there's any issue, then that whole service area is impacted. And he said that's really helpful. That's been helpful with like the I just completely forgot the electronic Epic, like looking at Epic and other large projects, seeing just the portion of the budget. So I don't know if that relates. Number one, Ms. Ruggles, if that's realistic to get, and two, commissioners, if you all would be open to that.
No, I think that would be a good start. Like, so, yes, definitely, you know, like if there are organizations that are responsible for a big chunk of a pie, and if they get in trouble, that big chunk of a pie will be in trouble. So, yeah, so it makes sense, you know, like to, you know, to start with that.
But, and Ms. Ruggles, is that something that, in other areas, not, you know, not contract fiscal stuff, it's easier to do, but is that possible for you all to provide if there was a presentation on, not every time a contract comes before, but if you all are looking at Health Right 360 or another huge agency, doing a little deep dive on that?
It's not, it's a project.
We do not have to an answer today, actually.
Just trying
Yeah.
to think about how, and like, if it's HR 360 are probably involved. It's really, there's a lot of program people though, part of this. It's not, like I might be the messenger, I guess, but if, you know, I don't know. There's some partnership with like the behavioral health services and the different sections, because they're gonna know the whole system. I think there's a pie chart probably of, I've seen it a lot in children's. I can't visualize it as much for adults for behavioral health, but I don't know each contract, but that's definitely something I think our system will be able to accommodate. But I think that's a good way to think about how, or at least it, like, I could
The-
pitch it, like how to.
Yeah, to define what big is, you know, in this situation. Yeah, I agree.
It's a big picture piece that I think is helpful.
And commissioners, if it's okay to wind down the discussion sometime soon, just so that we've got time. I need actually time in between to get the system ready for the next meeting.
Yeah.
Not need to end this minute, but if you could kind
Yeah,
of wind
no,
it down.
well, we can actually like wrap this up actually. So, because this can go on and on and on. Yeah.
Well, and then I'll work with Ms. Ruggles and staff, and we'll try to figure out what you've said and then what can be done, and then we'll bring it back. And there'll be some iterations before we end up calendaring it.
Yeah.
All right. Thank you, Ms. Ruggles, very much. So anything on emerging issues, commissioners?
Not on my end.
I think a lot of the emerging issues relate to the discussion we just had too. So
Great. And I'm noting that there's still no one in the public comment line.
And how, like, if there's a government shutdown, how would that impact
Oh, okay.
our service delivery?
Great. Okay, thank you. Item 8 is a public comment. We have no one on the line and no one in the room who's not staff. So we can go to consideration for adjournment, please.
move to adjourn.
I second. All in favor?
Aye.
Thank you, and thank you everyone for coming.
Thank you.